Welcome, everyone. I'm Mary Ray, co-founder of MyMSTeam, the largest and fastest growing social network for people living with MS. Already 1 in 9 people diagnosed with MS in the US is a member of MyMSTeam. And in fact, we have over 150,000 members worldwide that provide support and advice for each other. And if you haven't checked it out, please do so at mymsteam.com. We are so excited to have a full house today, over 750 pre-registered for tonight's event. I'm even more excited to be hosting someone who has a great sense of humor. His own YouTube channel with over 350 videos, 1.5 million views covering a range of MS topics, and an insightful video and article series on MyMSTeam, Dr. Aaron Boster. Dr. Boster is a neurology specialist focused on MS and is president and founder of the Boster Center for Multiple Sclerosis and a great friend to us here at MyMSTeam. Welcome, Dr. Boster.
Howdy, and thank you so very much for having me. I have to tell you, I've been excited about this for weeks. This is going to be a really special night tonight.
Well, given all the questions that we got before the event, I can tell you so many more people are really excited and interested in meeting you. So my personal connection to MS is actually through my mother-in-law, who lived for over 30 years with MS. Before we really dig in, do you mind sharing a personal connection that you have?
With pleasure. I decided to be an MS doctor when I was 12, not because my Uncle Mark had MS. I actually have no memories of my uncle without the disease. But I remember very vividly coming into the house, my grandmother's house. My uncle was in the living room in his wheelchair watching TV. My mother and my grandmother were sitting at the kitchen table holding hands, and they were crying. And they were trying to keep their voice down because they didn't want to upset my uncle. And they were crying because they couldn't get a hold of their doctor. And they were scared and they were alone. And I promised my mother at age 12 that I would learn to do it better, that I would learn to do it better than the men that were taking care of my family. Now, I didn't know that I was volunteering to do 27 years of school, or that I'd be near bald by the time I finished my training. I just knew that nobody should make my family feel that scared and alone. Nobody should make any family feel that scared and alone. This predates the interwebs. This predates therapy for MS. It's become my personal mission to help people, both care partners and patients alike, impacted by this disease, live their very best life. And it's my hope that together we can energize and educate and empower people impacted by MS. And that's why I love you guys so much, because it's part and parcel to what MyMSTeam is all about.
Thank you so much for sharing that, and that does ring true to me too. There's so much that we can do, and I think this forum is a great place to start. Tonight, we actually have a lineup of interesting questions that we collected before the event, as I mentioned. And for everyone on this Zoom conference, if you didn't send a question, don't worry. You have a chance to send questions through the Q&A feature in Zoom throughout this event. And we're going to wrap up in about 55 minutes here. Please note that Dr. Boster isn't able to answer specific medical questions in this forum. Those should be addressed by your doctor. So, all right, without further ado, I want to talk about a key thing that will involve our audience here throughout tonight's event. All of you will have a chance to answer some questions. In fact, here's the first poll question that we have for you all to answer right now. Hopefully you can see this. Question 1, what are you hoping to learn more about today? Oh, and Dr. Boster, you and I can't answer this question.
Okay.
Okay. I think, there we go. The results are in. Looks like a lot of folks, and nearly half the folks, are really interested in progression. and treatments and symptoms. And for those of you who selected other, whatever you had put in, if you haven't already, you can put your question other into the Q&A Zoom feature, as I mentioned. All right. So the first question I have for you, Dr. Boster. Again, this is coming from lots of questions that we had before this event started. What are some of the connections between pain symptoms and MS?
That's an awesome question. Full disclosure, when I attended med school about 3 years ago, they told me in class that MS didn't cause pain. And they were really wrong, like amazingly wrong. MS is a remarkable painful syndrome. And in fact, I count 11 different kinds of pain that are in some ways very unique to multiple sclerosis. For example, it's very common that people will suffer from optic neuritis, where the nerve that takes in the visual information becomes swollen. And not only do people have trouble and lose vision, but when they move their eye, they're pulling on that nerve and it causes immense pain. And that's a classic feature of optic neuritis. It oftentimes goes undiscussed. There was an article that came out this morning that looks at trigeminal neuralgia. Trigeminal neuralgia, the trigeminal nerve runs the face. It provides the sensory information for the face. And people impacted by MS are 20 times more likely to experience trigeminal neuralgia than the general population. It's insane. That's arguably one of the most severe pains that a human being can experience. I love hugs. I'm a big hugger. I'm from the Midwest. We hug everyone. But you don't want the MS hug. The MS hug, where you feel like there's a lasso that's crushing you, is a phenomenon where, because of a spinal cord lesion, the muscles between your ribs clamp down. And it can be excruciatingly painful, oftentimes confused with a heart attack or some other scary term. There's a phenomenon called Lhermitte's phenomenon. Now, Lhermitte is a dead French guy that named something after himself in the last century. But what he described is very common. When you bend your neck down, you're pulling on your spinal cord. You're kind of putting it under tension. And you can have ephaptic discharges. That's a doctor word for a zap, where you feel like there's electricity running down your body into your legs. It's extremely painful. And I have a lot of patients that won't move their neck because it hurts when they do. You can see other kinds of pain in multiple sclerosis. Spasticity is something that impacts over 70% of people with MS, where their muscles are fighting themselves. So when you want to bring your massive bicep in, your tricep doesn't let go, and you end up with a tug of war with your own arm. I can go on and list about 5 or 6 more. The point is, MS is very commonly associated with pain. And it's something that we have to face head on. People have to feel confident enough to tell their doc, look, this is not okay. And yes, I need help with it.
Right.
Because the good news is there's treatment for all the things I just listed. We can treat those symptoms and make them a thing of the past.
Along those same lines, Dr. Boster, we often hear about painsomnia. So you didn't get to all 11 types of pain associated that you believe are associated with MS. Is that a common concern among the patients you treat? Have you heard of that, where people, they may not call it that, but they just can't sleep because of the pain? Can you talk more about that and maybe some of the things that folks on this call who are experiencing that can maybe do? Again, obviously treatment, but.
My home is 120 years old. And during the daytime, it seems quiet. And at nighttime, my house is like a symphony of creaking and groaning and moaning. And in reality, those sounds are probably present during the day, but the TV's on and the kids are talking and the phone is ringing and we're otherwise occupied. And it's the same thing in our body. When it's quiet at night and you're finally laying down in your bed, trying to get ready to go to sleep, there's no distractions from discomfort. And it's extremely common, unfortunately, that pain, whether that be dysesthetic neuropathic pain, a foot that feels like it's on fire, or a hand that feels like it's icy cold, or a shoulder that feels like it's being crushed, these things are more likely to manifest for you to realize them when you're trying to sleep at night. And it's a horrible feedback cycle, because as you don't get restorative sleep, you hurt more. And so you can start to see a positive feedback cycle, and we have to break that cycle. This is extremely common. It is a tough thing to be up at night in pain.
Yeah, definitely. Well, on to the next question, because it's almost like it's perfect tee up to it. Um, how do I work with my doctor to find the best treatment option for me? And that could be a loaded question, but like you had said before, have the confidence to talk to your doctor. That's part of the how. But what advice would you give folks about this?
For starters, every human being who is subjected to something medical needs an advocate. 100%, you have to have an advocate. And I want you to cultivate yourself as your own advocate. I think that you have to be willing to say, hey, doc, I'm not actually okay with that. It's my body, my brain. I'm a voting member of this team, and I'm not comfortable with that. Now, some people are very uncomfortable with those thoughts. And so a pro tip is to write down the points that you want to convey. Prepare them ahead of time. Write them down on a piece of paper. Start the visit by saying, hey, I've taken some notes. There's some things that I want to discuss with you. I think that education is very, very powerful, and becoming educated about the disease process through connections that you make at MyMSTeam. Spending time on the interwebs and, nice locations like my YouTube channel, where you can learn about these therapies. You can learn the good, the bad, and the ugly, and you can bring that to the table and ask your doctor, what about blankety blank? Why not? What about this? And the goal here is not to have a fisticuffs. It's to have a discussion. I tell my patients, you are a you expert. You know about you more than anybody else, better than your husband and your kids. I mean, you're with you all day long. I read books you didn't read, which does not make me smarter than you, and it doesn't make me better than you. It just means I read other things. And so we're a team, you and I. I come to the table, you come to the table. I need to be a good listener. I need to understand your perspective, and I'm allowed to share where I come from. And then together we make what I refer to as a group decision. It's very important that you advocate for yourself. It's critically important. The doctor may feel uncomfortable, for example, but it's not his body. It's not her disease. It's your disease. And if God forbid you become disabled as a result, you're the one that's going to have to live with that. And so I want you to be your own advocate. I want you to feel comfortable saying, that actually doesn't jive with me. I want to talk some more.
There are a couple scenarios that come to mind. It happens to be both from like two different people don't know each other. One woman was sent home with 3 treatment options, and one of which might kill her, and wasn't given much beyond that. Another woman was pregnant, with MS, and her biggest concern was if there were complications from the pregnancy and treatment around that. And so for folks who have either a life stage factor or a scenario where they're given many options, what is the best way for them to broach that topic with the doctor? What are some key things a doctor needs to know?
I think it's important that you're able to elucidate your goals. I'll give you an example. When you meet with a financial planner, the very first thing they do is they assess your risk aversion. How comfortable are you putting all your life savings down on Japanese futures? How comfortable are you, or how okay is it to invest everything in stocks and bonds, right? And so in a very similar fashion, when you're meeting with your neuroimmunologist or with your practitioner, there has to be a discussion about your risk tolerance and what your goals are. And so I really think the conversation doesn't start with picking a medicine. It starts with discussing life goals. I want to know my patient's life goals. If you want to climb Monte Picchu, or you want to walk your daughter down the aisle, and by the way, she's only 4 years old, I need to know that, because we're gonna then influence our discussion based on those goals. And if your doc doesn't ask, I think you should volunteer. Say, hey, I was a concert pianist, and it is my plan that I'm going to do another piano recital. I'm going to have this baby, and I'm going to have this baby naturally, or whatever the case may be. Mm-hmm. So I think for starters, I think that we have to start thinking about what the goals are.
Yes.
It helps to have another set of ears. Mm-hmm. Your best friend, your pastor, your wife, whomever, having another set of ears, and actually having someone that takes notes, because in the moment it can be very overwhelming. And so you may need time to process. You may need to sit afterwards and kind of think through that. And then come back to the doctor with your questions. I can't stress the importance enough of taking time to think through what's going on and have an open dialogue.
On MyMSTeam, we definitely think about members and those who visit the wider audience as whole people, right? And I really like what you were saying as a doctor, wanting to understand what are the life goals, and thinking about oneself as a whole person's kind of tricky too. When you're sitting in an office at the doctor's office, you're kind of nervous. So I really appreciate you saying that, and hopefully our audience here is getting that boost of confidence as well. Before we move on to our next poll question, we did have a lot of interest around a couple of things, and it's up to you to see how we can address this. One is, what are some of the best ways to manage the classic symptoms, some of which you talked about, right, like MS hug, but things like drop foot and cog fog, the cognition fuzziness. And the other is maybe what are the most important things to know about brain lesions and MS?
Those are great questions. Let's break them apart. When we talk about symptoms, I really like to focus our attention on the invisible nature of the disease. So much of what takes you out of play is invisible. And honey, you look so good. You don't look sick. Well, you don't look uninformed, but you are, and so I like to make sure that with every single visit, we're addressing the up there's and the down there's. So the up there's, this is cognition, energy, and mood. And we have, and those are a triad. I talk about this a lot. I made several videos on it. If one is impacted, the other one is impacted, and in a similar fashion, we think about the down there's, bowel, bladder, and sexual function. It's invisible if you have difficulty maintaining an erection or you are incontinent of stool, but it sure does ruin your quality of life. And so I think with every visit, we have to weigh in. What's going on with energy? And if I'm listening to energy, I better be asking you about mood. And if I'm asking you about mood, I better ask you about cognition, because I can make your cognition better by indirectly helping your mood. I can make your cognition better by helping you sleep better at night, and so on and so forth. So I really think that we have to not shy away from those things. We have to recognize that the leading cause of loss of work in MS is not inability to walk. It's inability to think, inability to stay awake.
And once more again, what's that triad?
So mood? The up there's, in my mind, is a triad of cognition, mood, and energy levels. And they're tied together with a bow. And if we're trying to fix one, we have to address the other two. Now, mind you, they're all invisible. Sweetheart, you look so good. Oh, you're fine. Mm-hmm. You're not fine. You're just not talking about it. In a similar fashion, the down there's, bowel function. Are you having accidents? Are you constipated? Do you have pain? Bladder function, near misses, near accidents, wetting yourself, wearing pads, difficulty getting the urine out. And sexual function, because let's face it, there's very little in quality of life that goes beyond a good meal and intercourse. And so that's an important aspect of adults' lives. And MS can sometimes interfere with that. And we rage against that. We want to make sure that we can make you the best you in all aspects of your life.
That's great. I mean, from what I'm hearing is, with whatever the symptom is, understanding those 5 elements, the 3 up here, the 2 down here, are all the kinds of questions the doctor will want to ask you and maybe won't think to it. So if we can, as a patient community, come to you at the ready, knowing that about ourselves already, that's being a good partner with you.
That's exactly right. And that's why I want you to prepare your notes. I want you to write down. And in fact, and there's plenty of resources out there on the interwebs. You can even go online and print off a sheet and fill it out and bring it to your doctor. I love when patients do that for me. And that's a pro tip. If you have a concern, write it on a piece of paper and start the visit by saying, "Doc, I have some questions I wrote down." Culturally, she is now obligated to address your questions. And so that way, if you get befuddled or flustered or, something weird happens, you can go back to your questions. And if they say, "Okay, we're done," say, "No, we're not. I still have 2 more questions." And it's a way of making sure that your needs are addressed and you're not waylaid because you started to look at the MRI or something else.
Fantastic. Well, speaking of questions and some needs here, we have another poll question we like to put forward to our audience. What treatment option are you currently using? give folks a few seconds here, maybe about half a minute to get to this. Okay, the results are in. Disease modifying medications. That's not a surprise, is it, Dr. Boster?
I would hope not. I have a belief that I want everyone impacted by MS to be 4 for 4 in their fight against MS. And being 4 for 4 is a way of saying there are 4 things that I'm aware of that slow down the disease. Don't smoke, exercise is part of your lifestyle, supplement vitamin D and eat clean, and take a disease modifying therapy and make sure it's working. So I'm really stoked that a lot of people identify that as something that they're doing. It's one of the major opportunities to change the natural history of this disease. The natural history of this disease is not a very nice discussion at all. It involves a lot of words that I don't want to mention. And the best way to rage against that is to be 4 for 4 in your fight. And key in that 4 for 4 is to take a disease modifying therapy for sure.
You had mentioned smoking. Other lifestyle things that come up are things like, diet and exercise. So one question that had come through is, how can diet be used as a complementary treatment for MS? Absolutely.
It's a fool who thinks that they're going to fix a complex condition like MS by taking a pill. That's nonsense. And if you're not in it to win it, if you're not willing to really look at the depth and breadth of all the options to make you the most awesome you despite having MS, it makes me sad. We can do a lot with diet and exercise, a lot. And let's just focus on diet for a second. Now, if you are bored, go and post-COVID era, go to the mall and walk into a bookstore and declare that you have MS, because they'll freak out. They'll be like, oh, and they'll bring you over to the bookshelf and they'll show you all these books with people that have initials after their name, like mine. And the reality is that there's no diet that has been proven to slow the disease. But I feel confident that diets can improve symptoms. I have seen patients change their lives dramatically by adhering to a diet. And before you ask me, like, well, what kind of diet? I have a very simple rubric that I would recommend, and it's not easy to do. Now, it might be easier in an enlightened place like California, but here in the Midwest, it's a little bit of a challenge. And here it is. Are you ready?
Yeah, let's hear it.
Eat real food. Eat whole food. So don't eat fake food. So McDonald's is not real food. If you buy a McDonald's hamburger and leave it on your dining room table and come back 3 years later, guess what? It looks just like a McDonald's hamburger. It doesn't rot. Soda pop is not real food. I want you to eat foods that have ingredients like apple, chicken, kale, right? I don't want you to eat foods that have ingredients you can't pronounce. I want you to avoid overly processed foods, fried foods, fast foods. Those aren't actually foods, they're chemicals. And I double dog dare you, if you take this challenge for a month and eat real food, you will be amazed at the energy that you have, the clarity of thinking that you have, the better control of your bladder that you have. It's darn near magical. And if you don't believe me, try it out for a month and let me know. It can be life-changing.
And again, to be clear, we're talking about complementary, not because when you said, it's not just the pill, but of course, we opened up with disease modifying treatments. It's not the end all be all, but certainly a great start. And then adding on lifestyle changes like stop smoking, don't smoke, and eating these real foods really matters. Thank you so much.
It's not like pie where if you take a piece, someone else doesn't get some. You can do all these things. You can exercise as part of your lifestyle. You can eat clean. You can supplement vitamin D. You can avoid lighting things on fire and breathing them in. And you can take a disease modifying therapy.
Got it. We have a question that's come in, and it's before I ask the audience No, I'm sorry. Before I ask you about relapse remitting MS, this question came in from Rachel. Are you more susceptible to other neurological diseases such as Parkinson's or dementia with a diagnosis of MS and a family history of those diagnoses?
No. So if you have one autoimmune condition, you're more at risk of having a second autoimmune condition.
Okay.
But having multiple sclerosis does not increase the probability of having Parkinson's disease or Alzheimer's dementia, not at all. Now, sometimes nature's too generous and you can have two things going on, but you're not at increased risk of those conditions just because you have MS.
That's great to hear. So what are some of the most effective treatments, just coming back to MS solely, for relapse remitting MS?
So that's a very charged question. And I have to share with you that the way that I approach this is maybe a little bit different than other people, but you're stuck listening to me, so I'll at least share my opinion. And my opinion doesn't make me right, it just makes me really opinionated. I want to place you on the most effective drug you're comfortable with. Now, I chose those words very carefully because just because there is a more effective drug, it doesn't mean that you're actually comfortable with it. But I want to put you on the most effective drug that you're comfortable with. I'm really excited because just a couple of weeks ago, we had our big international MS convention, the ECTRIMS convention. Now this year it was virtual, but we still had it. And I was delighted that one of the themes that emerged from this big Congress was the evidence is starting to pour in that the earliest application of the highly effective medicines work best. And the flawed escalation model is in fact not a good approach to managing MS. And that's music to my ears. I've been chanting that for a long time and nobody has listened for a while. So I'm really, really delighted. And so what are those drugs? In my biased opinion, I'm talking largely about monoclonal antibodies and biologics. Medicines like alemtuzumab, codenamed for Lemtrada, medicines like natalizumab, codenamed for Tysabri, medicines like ocrelizumab, codenamed for Ocrevus. These are highly effective medicines, not just in their ability to cut down relapses and stop new spots on MRI, but in their ability to achieve confirmed disability improvement, where you go up the down escalator and you lose disability, which is a colossal thing to see, in their ability to slow brain volume loss so that your brain can age naturally, and the ability to achieve NETA, no evidence of disease activity. And in the modern era, we have moved so far past the 90s where it was okay just to not have attacks. We're way past that nowadays. And so we really want to use the most effective medicine as early as possible for the best outcome.
Got it. Early. That's good to know. But along the same lines, we're going to go into our next poll question here regarding what stage our audience is at with their MS. What stage of MS are you experiencing? And while folks are answering, Dr. Boster, there was a question that maybe we can get answered here about what do people need to know about getting flu shots and avoiding flu and COVID in the fall and winter? I mean, we're in October now. Fall just started. Any tips?
Absolutely. Now, the first disclaimer is you really do need to talk to your doctor about the specifics for you, because there can be all kinds of situations that are unique to you as an individual. I'm going to make some general comments. My first general comment is get your damn flu shot. All right? So go get a flu shot. A flu shot is a dead vaccine, so there's no concerns about trigger or relapse. And flu can kill people. Flu is no joke. Flu takes your life 11 years. There's thousands of people that succumb to flu. And if you are on an immunosuppressant, we have to time the flu shot, right? If you take the flu shot off cycle, it might only partially work, but that's better than not working. So get your flu shot. I think that's very, very important. Now, again, there are specifics for each individual, each disease-modifying therapy, and the timing of that therapy, which is relevant. And so you definitely need to have that conversation. But the take-home is get your damn flu shot.
Okay.
I got my flu shot. My daughter got hers today. This is real, and it's something that we can treat. When you get a flu shot, it doesn't just help you, it helps me.
Fantastic. And I'm just looking for the poll results, and here they are. Again, I don't think this is a big surprise, but relapse remitting, topping the list here. Is there anything that you're noticing? Is this consistent with what you see in your patient population?
Yes. I think 85% of folks impacted by MS have a relapsing form of multiple sclerosis. A relapsing form of multiple sclerosis is a journey, clinically isolated syndrome, so-called relapsing MS, so-called secondary progressive MS. About 10 to 15% of folks have a primary progressive phenotype. Now, I am of the belief that there's no such thing as benign MS, and I can prove that if you let me do neuropsychometric testing or some advanced neuroimaging. So I don't believe that benign MS is actually an entity. I think that's a misnomer born out of a mistake by the Mayo Clinic back in the day. But I think most people that have MS have a relapsing form, and I think that's reflected in that poll for sure.
For those who are experiencing any progression in the disease, what treatment changes should members consider talking about with their doctor?
First off, MS does not have stages like cancer, stage 1, stage 2. I remember very vividly early on in my career, patients would say, "Doc, please don't tell me I have SPMS. Please just don't tell me that," as if that meant that they were done. They need to pack it up and hang crane, wait to die, and that's simply not the case. The reality is that it's much more complex. The reality is that progression starts from the onset of the disease. And we're now starting to become a little bit more enlightened in the way that we think about MS. I'll share with you very briefly an exciting evolution, which was highlighted at this Congress, and that's the concept of PIRA, P-I-R-A, progression independent from relapse activity. Let me break this down for you quickly. When you have a young person newly diagnosed with MS, and you look at them over a period of just a couple of years, they can accrue neurological disability from 2 causes. The first one is they have an attack and they don't fully recover, right? So if I, God forbid, have an optic neuritis and I'm blind in my left eye, and then it comes back halfway, and now I'm legally blind, but I can still see stuff, I have accrued disability because I didn't fully recover. In reality, there's a lot of progression independent from relapses that occurs very early on in the disease. We're now starting to become very savvy about how to tease that out in clinical trials. And we have good evidence that some of the more effective medicines are actually able to quell not just the relapse rate, but also PIRA, progression independent from relapse activity. So my take home here is treat your disease. There is a plague amongst MS neurologists. There's a misunderstanding that we should stop disease modifying therapies because people age out. If I use polite language, that's bullshit. It is a terrible, terrible thing. And I can't tell you how many times I've seen a 60-year-old that was ripped off their medicine. They don't have an attack, but they pick up a cane, they pick up a walker, they progress in their disability. And so if you're stable like Mabel and you're winning, maybe that's because your disease modifying therapy is working. And so I want to leave this question with the comment that we need to treat your disease. And as long as you have an immune system, and as long as you have a nervous system with features that you like eating, swallowing, orgasming, seeing, listening, then I want to keep that nervous system protected. We want to preserve the reserve, the neurological reserve. And one of the very best ways we can do that is to keep on keeping on with our disease modifying therapy.
So preserve the reserve. So there's no suggestion of reversing and adding to the reserve, excuse me.
So the
Because that's a common question right now, because I think that's a maybe misunderstanding in general of, there are questions that people have, like, how does MS progression work? Can it be halted? But as you said, it's about treating the disease. But the way that metaphor of preserving that reserve, it kind of makes me feel a little torn in the understanding.
The goal in MS is to allow your brain to age naturally. Right? You want, as you grow older, you want your brain and your nervous system to age naturally. You don't want it to age in an accelerated fashion. And managing cardiovascular risk factors, for example, When you manage cardiovascular risk factors, you help slow the aging of the brain so it doesn't age prematurely. I'm talking about controlling high blood pressure, and I'm talking about controlling high blood pressure to slow MS progression for Rizzo. I'm talking about managing high cholesterol. I'm talking about managing diabetes and morbid obesity. These are important factors, not just like so that you live longer and your heart's okay, but so that your brain ages naturally. In the modern era, we are allowed to demand NEDA, no evidence of disease activity, and we are allowed to request confirmed disability improvement. Allow me to repeat, confirmed disability improvement means that you lost a disability. You dropped the cane, all right? You walked farther, you climbed a mountain. And I have seen this in my clinic time and time again. It's not something that every person in 2020 gets to experience. But boy, when it happens, we raise the roof. It's very, very exciting. And so, right now we don't know how to add water back to the pool, as the pool drains, but we can slow that down big time. And we are on the cusp of introducing an entire era of medicine where we remyelinate. And we are a little farther along, farther down the line in bringing neuroprotective agents to the market. But, I really think that within 5 years, we will probably have remyelinating agents, 5, 8 years, we'll have remyelinating agents that will hit the market. And they will be used in conjunction with the current DMTs. It is an awesome time to have MS. And let me understand, I don't wish MS upon you, but if you have to have the disease, now's the best time to ever have it because of what we can do.
Understood.
I want to keep you in the best shape possible so that when that remyelinating agent becomes available, we can give it to you.
So I just want to bring in a real quick question. This is a little specific, but it's about lesions from Natalie. And I don't want to, again, Dr. Boster isn't addressing specific medical questions. You should address that with your doctor. But she does have this question about her lesions. I have, why do I not have new lesions, yet the symptoms are getting worse? And I'm not going to try to play doctor, but I immediately am going back to the up here and down here.
So let's talk about that. Let me give you an example. Now, as a full disclosure, I don't own a firearm, okay? But let's pretend that I owned a shotgun, right? So I've got a shotgun and I blow a hole in the wall behind me, all right? And I choose not to repair it because what the hey, that was kind of neat. Now I got a giant hole in my wall. All right. Now I mentioned that my home's like 120 years old. And so if we fast forward 30 years and the structural integrity of my home starts to wear down, which wall falls first? The wall with the structural damage. When you have a lesion, let's call a lesion what it really is, guys. It's brain damage. All right. That's what we're actually talking about. Is damage to the holiest of holies, the supercomputer that runs the body, the only untransplantable organ system. When you have a lesion, you have brain damage, your brain rewires. But it can only rewire so much. And as we age and as our brain ages, those areas wear out. And when those old areas that rewired wear out and you revisit that disability, that's progression. Mm-hmm. And so you don't need new lesions to have a reemergence of symptoms. And sometimes you'll hear people say, my left leg was my good leg. My right leg has been bad for years. Now my left leg is starting to give out. Why am I not seeing anything on my MRI? Well, there's stuff on your MRI. It's old, but it's 15 years old and it's starting to wear out. And so in many ways, when you have an attack or when you have a new lesion, you pay what I call the devil's price. You pay now and you pay 15 years later. And in the modern era, 2020, we don't know how to make that lesion go away yet. So what we want to do is we want to prevent it at all cost. We want to prevent the hole in the wall, not for now, but for later when we want the house to stay standing.
Mm. So we're getting a lot of questions around treatments, and it's begging for another live question and answer session. So I think I'm going to reserve some of them, but there was one question about DMTs. Can you stay on them for life? For example, Ocrevus.
So I'm a very firm believer that you should not use disease modifying therapies after death. The drugs have not been tested after death. We don't think they work very well. And so I agree that you shouldn't continue them post-mortem. I don't think that's a good idea. However, up until death, I think it's fair game, as long as you have a nervous system with functions that you like. So I take care of a lot of really spry 70 somethings that ride horses for Rizzle, like they do. I take care of 70 somethings that work 60 hours a week. I take care of 70 somethings that are in it to win it. And you know what they do at night? They have awesome sex. All right. So they are involved in life fully, sometimes more than 30 somethings. And so my point here is, how dare you ever take away what is making them successful? How dare you even act in a way to be so ageist as to remove their option of living and thriving despite having this condition? I think that's abominable. And so I do agree that we should not treat after death, but up until then, I think it's on.
Okay. Well, great. I think others would agree, like, don't treat a dead body for sure.
That's not a good idea.
No, not a good idea. Yeah. So on to future, the future of MS, but even what's happening now, how might stem cell treatment impact MS? And what are some of the newer treatments available? You had mentioned in 5 years. Anything you can share or shed some light on for the audience?
Absolutely. Let's talk about stem cell transplantation. It's a super hot topic. And it's in part a hot topic for the wrong reasons. And it's in part a hot topic for the right reasons. So stem cell transplantation sounds sexy as heck, right? I've got this condition, whatever it may be. I'm going to swap out my bone marrow and then I won't have it anymore, right? So I take some upfront risk and then I'm winning. And it's not that straightforward. Stem cell transplantation, in my opinion, should not be done outside the context of a clinical trial. Now, there are a lot of stem cell tourism around the world right now where you can fly to an exotic place like Mexico or India or Chicago. And if you give someone between $25,000 and $200,000, they will swap out your bone marrow. Sometimes the only thing good about that is they're not actually doing a real stem cell transplantation. But a lot of people are taken advantage of, and I think that is abhorrent. Stem cell transplantation is becoming something that's very exciting. And when you study the medical literature, we're getting better and better at it. I participated in a clinical trial called the HALT trial, HALT, where at my institution, we did 4 stem cell transplants. It's not a cure. Not today, it's not a cure. But it is arguably one of the most impactful anti-inflammatory therapies that are currently available. And I don't think it should be done outside of research today. Now, that may change down the line, and there's a lot of really exciting investigations studying that. And so I don't think we should shy away from stem cell transplantation, but I want you to do it in the context of a safe environment with qualified people, because it's not child's play.
Yeah.
There are, in my opinion, we need 3 kinds of medicines to beat MS. We need an anti-inflammatory medicine. And right now there are 22 FDA-approved anti-inflammatory medicines on the market. Now, before I say anything else, we have to give a shout out to people with MS who volunteered their bodies to help us figure that out. When I entered into this field, we had 3 medicines to treat MS. 3, right? Now we have 22. And if people with MS didn't volunteer their bodies to help us figure out, we would have no medicines. So if you're listening to this and you're taking a medicine, I want you to thank someone that came before you, who maybe isn't around anymore, who had the foresight to give the most holy gift possible, their own body, to help figure out how your therapy would help you. So if you have a glass of water like I do, raise your glass and let's toast those people, because that is an amazing thing that they've done. Thank you very, very much, everyone. And so I think that we really have to keep that in mind. Now, anti-inflammation is only one of 3 things that we need. I made mention earlier that another thing we need is we need to remyelinate. And there are a lot of remyelination trials going on right now. A lot of them have been letdowns. They haven't worked out, but we're going to keep on keeping on. There's an old expression: if you keep banging down the door, one day you're going to knock it down, and we're going to knock it down. And there's another thing that we need. We need a neuroprotective agent, and we just don't have that yet. And so we're farther along than we've ever been, but we're not done with the ride yet. And so I think what's coming is very, very exciting. I just opened up a center. It's been a labor of love. And one of my most exciting achievements is that we are participating in some really exciting clinical trials, studying some novel agents that have never been used in MS before. There's these molecules called BTK inhibitors. So butyrine tyrosine kinase inhibitors, there's these small molecules and they do some wackadoodle things that are really cool. For example, they work in the brain at slowing down a cell type called microglia that we've never been able to touch before. It's an entire cell line that we've never been able to manipulate. And now we're going to be able to do that. And so the future is really, really bright. And I'm excited to participate. I really am.
It's great. It's exciting to hear too. We're almost out of time. And before we go, we have one more poll question. How many posts, this is almost like a trivia question here. You get the honor of your own pat on the shoulder. How many posts have been made on MyMSTeam since the social network was launched in April 2013?
I got my answer. I'm guessing.
We cannot vote, I will remind the panelists. And I'm actually gonna, while we're filling this, while folks are answering here, I'm gonna see if there's any other, what should someone look for when finding an MS doctor? What do you think the criteria should be, Dr. Boster?
So I recently had a friend of mine say, Aaron, you're a lot like Nebraska. So what do you mean I'm like Nebraska? And she said, well, Nebraska has a new state motto. Look it up. So I did. The state motto of Nebraska is, we're not for everyone, like quite literally. So I'm not going to be the right doc for everybody. And you're not going to be the right patient for every doc. And it's really a marriage. It's a coming together. It's a team. I refer to it oftentimes as a village. And so the first and most important thing is you have to feel comfortable talking to your doctor. A very dear patient of mine, someone that I've been very proud to take care of, sent me an email and said, you know what, I don't know if I'm going to stay in your practice anymore. And I'll be honest with you, it made me cry. But I was so honored that she was comfortable telling me that. That's the kind of relationship that I want. Every person in my practice has my cell phone. And I've had my cell phone sitting next to me the whole time and it hasn't gone off once because people are respectful. And I think the point here is the most important thing is you have to feel a connection with your doctor, because that's going to be a key team member on your team to make you live your best life despite MS. And so if you're not feeling the love, you're going to get a different doctor, right?
What would you advise, though, those folks living in a place where they only have a regular neuro and not necessarily someone as versed in MS as you, or just someone who did specialize in MS? What advice would you give them?
So I'm going to give you a very biased answer, all right? And the reason I say that is 80% of people in the United States impacted by MS are not cared for by neurospecialists, like folks like me that did extra training, and that's all we do. The majority, the 80% of people impacted by MS are cared for by very well-intended general neurologists. And if there is a silver lining to a global viral pandemic, it's the use of telemedicine in the United States. I have done more consultations out of state and out of country in the last couple months than I ever have in my entire life. And, a very comfortable phenomenon is you have your local neurologist or your local primary care doctor. And then you have someone like me that maybe you only come and see once or twice a year. I have people that will fly in from out of the country or out of the state, and they'll come and spend time with me once or twice a year. We do all the rest on telemedicine. Back in the day, before telemedicine was cool, we would just do telephone. And my point is that, people will go to great lengths to make sure they have an awesome television set. People go to great lengths to have a really, really nice yard. I want you to invest in your only untransplantable organ system, your brain and spinal cord. Can't replace them. And if that means that twice a year you drive a couple hours to see someone that you connect with who is really in it to win, to help you live your best life, I would argue with you that that might be worth it. I spent a lot of time liaising and working with other doctors, and we get along swimmingly well, I think. Really, they don't tell me, but my point here is, we can share that, we can help. And if we make the only goal, making that family the most awesome family possible, everything is aligned. And so I challenge someone who says, well, I live in fill in the blank and there's nobody near me. Well, how'd you get a hold of me? You You could do a telemedicine visit. You could take a road trip. I mean, come on, there's nothing more important in my mind than keeping your mind intact. And so, my biased advice is seek out somebody that connects with you. Seek out somebody that is really spending all their time thinking about this condition and how to beat it, and partner with them.
That's great. This is all fantastic advice. Going back to the poll question, I didn't give anyone a hint. I'd love to see what the results are that people had. 10 million, I will say my MS team has the most conversation going on the English speaking internet. That is for sure. So the answer is actually 1 million. And I'm not surprised if we'll get to 10 million eventually, especially after this live event. Thanks a lot for sharing. For those of you who haven't joined my MS team so far, I know we have quite a few members on this call right now. Know that you can join. It's a free social network. And that's a lot of sharing you see with 1 million posts. You'll never feel alone. And whatever you may be experiencing, likely someone on my MS team has gone through it as well. Thank you so much, Dr. Boster, for all this fantastic advice. There's so much information here, and there are so many great questions coming through. We are absolutely going to have another event before the year's out, if not 2 events. I will say, if there's any parting words that you have, Dr. Boster, for the audience before we go, what's the one thing out of all these questions, what's the one answer you want them to take away from today's live event?
I want you to live your life and not allow MS to interfere. I don't want MS to make decisions for you. And I'm not talking about an attack, right? You don't need to go to doctor school to discuss an attack, right? I'm not talking about stopping spots on your MRI. I'm talking about the litmus test of life. If you're not going to your son's baseball practices anymore because you can't traverse the grass, we're not doing the best job that we can. And I don't want you to settle for that. All right. If you need to reduce your hours at work because you can't stay awake, we're not doing our best job. And so I want you to become selfish. It's your body, it's your brain, it's your life. And we are here to lift you up. We are here to surround you with a village, with a team to help make you the most awesome you possible. But that starts with you. You are the key village member. And if I have one comment, I want you to be terribly selfish because you only get to do this once. And I want it to be an awesome ride.
Well, thank you, Dr. Boster. I want to end with one quote from Sal Stavali. Thank you, thank you, thank you. You deliver info with such conviction, energy, and enthusiasm. I feel better just watching your videos. This is great. This has been a great time, Dr. Boster. I look forward to doing this again. Cheers to you.
Peace. Thank you, everyone. Have a great night. I hope we do this again very, very soon.
Cheers.
Take care.